The purpose of this module is to give an overview of shock definitions, symptoms, and treatment. Shock occurs when there is not enough oxygen delivery to meet the needs of the surrounding tissue. Basically, oxygen supply is less than the oxygen demand. This will lead to hypoperfusion, which can cause organ damage. Treatment should be initiated as soon as possible. The goals of treatment should be to reverse perfusion abnormalities, restore organ function, and prevent cardiac arrest. Recognition of shock may be difficult for the pharmacist since we are not hands-on with the patient. However, we can watch the monitors for heart rate, blood pressure, oxygen saturation, and ECG changes. Warning signs for shock generally include tachycardia, absent peripheral pulses, weak central pulses, cold extremities with prolonged capillary refill, and altered mental status. Hypotension is also present, but is usually a late finding. The body can compensate up to a certain point, which is why hypotension may be a late finding in the presentation of shock. The severity of shock is classified as compensated or decompensated. In compensated shock, the patient is usually normotensive despite poor perfusion. In decompensated shock, the patient will present with hypotension. The decrease in blood pressure is seen because the compensatory mechanisms have failed. Shock can be broken down into 4 different types: hypovolemic, distributive, cardiogenic, or obstructive shock. Hypovolemic shock is the most common form of shock seen in children. It is usually due to dehydration that may be the result of GI problems such as vomiting and diarrhea, excessive urination as seen in DKA, or a capillary leak due to a burn injury. Distributive shock occurs when there is an inappropriate distribution of blood volume due to low systemic vascular resistance. This can lead to an inadequate oxygen delivery to other organ systems. The most common causes of distributive shock are sepsis or septic shock, anaphylaxis or anaphylactic shock, and spinal cord or head injury or neurogenic shock. Septic shock may then be further described as warm shock or cold shock. Warm shock is an early compensated state of septic shock. The patient will present with warm extremities, bounding pulses, tachycardia, wide pulse pressure, decreased systemic vascular resistance, and increased cardiac output. Cold shock is the late compensated stage of septic shock. There will be a drop in cardiac output and systemic vascular resistance. The patient will present with cold, clammy skin, rapid, thready pulses, and shallow breathing. Cardiogenic shock is characterized by myocardial dysfunction. In cardiogenic shock, intravascular volume is adequate or increased, but inadequate myocardial function limits stroke volume and cardiac output. Obstructive shock is caused by a condition which will block or impede blood flow to other organs, usually the heart or lungs. Treatment should begin as soon as possible. The primary goal in treatment should initially be to reestablish tissue perfusion using fluid therapy and possibly vasoactive drugs. During the first hour, the PALS algorithm for treating septic shock is to give repeated 20 milliliter per kilogram boluses with an isotonic crystalloid fluid such as normal saline, correct hypoglycemia or hypocalcemia, administer the first dose of antibiotics STAT. Blood cultures should be drawn prior to starting antibiotics. Consider a vasopressor drip and a stress dose of hydrocortisone. Determine if the patient responded to fluids. If they did not respond to fluid resuscitation efforts, then start a vasopressor drip. The vasopressor drip to use is determined by the patient's blood pressure and vessel dilation. If the patient is normotensive, start dopamine. If the patient is hypotensive, warm shock, meaning they have warm extremities with bounding pulses, tachycardia, wide pulse pressure, decrease systemic vascular resistance, and increase cardiac output, start norepinephrine. If the patient presents in hypotensive cold shock, meaning there has been a drop in cardiac output and an increase in systemic vascular resistance, and they are cold and clammy with thready pulses and shallow breathing, start epinephrine. We have to work on correcting the metabolic abnormalities that are causing the shock symptoms, and we will go a little more in depth on those individual treatments and doses of medications that you may see used to manage shock in a code or trauma situation. Hypoglycemia is often seen in septic shock. Hypoglycemia is very common in patients that are dehydrated. If the serum glucose is low, it can adversely affect cardiac function and lead to brain injury. Dextrose solutions are usually available in 50% solutions. A vial of dextrose 50% can be found in the code bag as well as in the crash cart. The maximum concentration of dextrose should not exceed 12.5% for peripheral lines and 25% for central lines. Hypocalcemia is another common abnormality seen in septic shock. Calcium is essential in the body for proper cardiac function and vasomotor tone. If the patient presents with a low ionized calcium, then calcium should be replaced. At Children's, we have calcium chloride and calcium gluconate. Calcium gluconate has 1/3 as much elemental calcium as calcium chloride. The replacement dose for calcium chloride is 10 to 20 milligrams per kilogram per dose, administered undiluted. If calcium chloride is being used for cardiac arrest, the dose is 20 milligrams per kilogram per dose, administered undiluted. Calcium gluconate should be diluted with D5W or normal saline to a concentration of 20 milligrams per ml. Hyperkalemia may be seen in the presence of renal insufficiency, severe metabolic acidosis, or cell death. If the patient presents with a high potassium level, we would want to treat this quickly. Calcium is given first to calm the heart. Insulin and dextrose, followed by Kxalate, should be used immediately to treat a high potassium level. Diuretics may also be used to help excrete potassium from the body. Albuterol nebs may also be given as adjunctive therapy. Metabolic acidosis is another abnormality that can be seen in shock. It's usually caused by the production of acids such as lactic acid when tissue perfusion is inadequate. If using vasopressors, keep in mind that the effectiveness of vasopressors may be impaired when metabolic acidosis is present. Therefore, correcting the metabolic acidosis and vasopressor therapy must be done together. Initially, metabolic acidosis is treated with fluid resuscitation and with an inotrope such as epinephrine to help restore tissue perfusion. In severely ill patients, sodium bicarbonate at a dose of 0.5 to 1 milliequivalent per kilogram per dose may be given. Code doses for sodium bicarbonate may be 1 to 2 milliequivalents per kilogram per dose. When treating a neonate or infant, dilute the sodium bicarbonate 1-to-1 with sterile water. As mentioned earlier, fluid therapy is very important in the treatment of shock. It's usually one of the first steps in treatment. Fluid resuscitation for hypovolemic and distributive shock should be started with crystalloid fluids such as normal saline or lactated ringers at a dose of 20 milliliters per kilogram given IV over 5 to 20 minutes. For cardiogenic shock, smaller doses of 5 to 10 milliliters per kilogram of normal saline may be given. Do not give dextrose-containing fluids for volume resuscitation in shock due to the potential for osmotic diuresis. Now we'll discuss some of the specific pharmacological agents used for the treatment of shock. These include inotropes such as epinephrine, dopamine, and dobutamine, used to increase cardiac contractility, increase heart rate, or produce variable effects of systemic vascular resistance. Epinephrine works by stimulating alpha-1 and beta-1 receptors. At higher doses, epinephrine will stimulate the alpha receptors. Alpha-1 receptor stimulation will cause vasoconstriction, which will increase diastolic blood pressure. This will increase myocardial and cerebral blood flow during CPR. At smaller doses, epinephrine will stimulate beta receptors. The beta-1 receptor stimulation will cause an increase in heart rate and myocardial contractility. Indications for the use of epinephrine would be ventricular fibrillation, pulseless ventricular tachycardia, pulseless electrical activity, bradycardia, or asystole. Code doses of epi are covered in the cardiac arrest module. The next inotrope that we will discuss is dopamine. The standard concentration of dopamine that is found in the crash cart and code bag is 1,600 microgram per ml premixed dopamine bag. Dopamine infusions are usually started at 1 to 20 micrograms per kilogram per minute, up to a maximum rate of 50 micrograms per kilogram per minute. If the dose is greater than 20 micrograms per kilogram per minute, the patient will also need to be on an epinephrine drip. The last inotrope that we occasionally see used in a code or trauma situation is dobutamine. Dobutamine will increase the contractility of the heart by stimulating beta-1 receptors. This will also increase the heart rate. It will also work on beta-2 receptors, which can cause vasodilation and hypotension. Like the other inotropes, dobutamine is not compatible with sodium bicarbonate. The next class of drugs that we can see used to treat a patient in shock are the phosphodiesterase inhibitors. These medications are used to reduce afterload, improve coronary artery blood flow, and improve contractility. The most common one that we see used is milrinone. Milrinone increases myocardial contractility and reduces preload and afterload through the relaxation of the vascular smooth muscle. Administering a loading dose is optional. The longer the loading dose is infused, the less chance of developing hypotension. The loading dose is usually followed by a continuous infusion of 0.25 to 0.75 micrograms per kilogram per minute. Vasodilators, such as nitroprusside, nitroglycerin, and hydralazine, may also be utilized in the treatment of shock. Vasodilators are used to reduce afterload and reduce venous tone. Vasopressors are the most common drugs that we see in the treatment of shock. Epinephrine, norepinephrine, dopamine, and vasopressin are all considered vasopressors. Since we've discussed epinephrine and dopamine, let's spend some time talking about norepinephrine and vasopressin. We'll most commonly see norepinephrine used in hypotensive shock that presents with low systemic vascular resistance that has been unresponsive to fluid boluses. Norepinephrine will activate alpha receptors to increase smooth muscle tone and will activate beta-1 receptors to increase heart rate and contractility. When possible, norepinephrine should be administered via a central line, and it should not be administered with sodium bicarbonate. You'll find all the necessary supplies to make a norepinephrine drip at the bedside, code bag, or in various Pyxis machines in critical care areas. The drip can be made by adding 11 milliliters of 1 milligram per ml norepinephrine, which is 11 milligrams, to a 100 ml bag of normal saline. The resulting solution will be a norepinephrine drip at a concentration of 100 micrograms per ml. A drip is usually started at a rate of 0.05 to 1 micrograms per kilogram per minute, up to a maximum dose of 2 micrograms per kilogram per minute. Vasopressin is indicated for use in cardiac arrest and refractory septic shock. Vasopressin increases cyclic AMP, which will increase water permeability at the renal tubules, which will result in decreased urine volume and increased osmolarity. Vasopressin acts as a direct vasoconstrictor without inotropic and chronotropic effects. It will increase systemic vascular resistance and mean arterial blood pressure and decrease heart rate and cardiac output in vasodilatory shock. Vasopressin is a vesicant, so administration through a central line is preferred. Use vasopressin with caution in patients with hyponatremia and asthma. We mentioned the possibility of giving a stress dose of corticosteroids for septic shock or anaphylactic shock. If this is necessary, we will usually use hydrocortisone at a dose of 2 mg per kilogram per dose or 50 mg per meter squared per day. Shock is one of the most common issues we see when we are called to a code or a trauma. Being able to recognize the signs and symptoms early and begin treatment quickly is key. To review, fluids. 20 milliliters per kilogram fluid boluses should be initiated as soon as possible. The next step involves correcting electrolyte abnormalities that may be contributing to the shock symptoms. Administer antibiotics if needed, consider vasopressor therapy, or stress dose of steroids. When trying to decide which vasopressor to use, keep these key points in mind. Dopamine is for normotensive patients. Norepinephrine is for hypotensive patients in warm shock. Epinephrine is for hypotensive, vasoconstricted patients in cold shock. This concludes the module on shock. You may review it again at any time.